classes, we have dealt with upper GI bleed and as well as the lower GI bleed. So the remaining class was about the obscure GI bleed. Dr. Pavan will take us through the causes of obscure definition of obscure GI bleed, causes and its management. So I request Pavan to start the class.
Good evening to everyone. I am Dr. Pavan Kumar, first year DNB resident from Sagar Hospital. Today I am going to discuss on obscure GI bleeding. Obscure GI bleeding. When any bleeding that persists or recurs even after an initial negative evaluation with upper and lower GI endoscopy is defined as obscure GI bleed. And the most common source for obscure GI bleed is small intestine. And obscure GI bleed accounts for 5% of the GI bleeds. And the most commonest causes are vascular ectasias, variceal bleedings, neoplasms, and small bowel ulcers. And we have to keep in mind that the rarest causes of obscure GI bleedings like aortoenteric fistulas, hemobilia, and hemosuccus pancreaticus. Obscure GI bleeding can be further divided into two types, that is obscure occult bleed and obscure overt bleeding. Obscure occult bleeding, that is bleeding that is not apparent to the patient and which can be picked by some investigation like stool occult positive stool occult blood and iron deficiency anemia. Whereas in obscure overt bleed, the bleeding is visible in the form of hematemesis, melena, or hematochezia. In obscure occult bleeding, if the patient have no systemic signs of disease after repeated endoscopies, and we consider the patient as a iron deficiency anemia, and we give the subsequent iron therapy. And 80% of the obscure occult GI bleeds are resolved with their symptoms within few years. The slide shows various differential diagnoses of the obscure GI bleeds. Starting from the upper gastrointestinal tracts like angiodysplasias and peptic ulcer diseases, and small bowel diseases like Crohn's disease and Meckel's diverticulum, and colon diseases like ulcerative colitis, Crohn's disease. How we are going to evaluate patients of obscure GI bleeding. In obscure GI bleeding, the history and physical examination is
Pavan?
Hello, Pavan.
Pavan?
cases.
Yeah.
Pavan?
Are you there?
Objective evidence of gastrointestinal bleedings.
Pavan?
Sir? Hello?
Screen stopped.
You have to share your screen, Pavan.
There was some network issue, I think.
Yes, sir.
See, if you have problem with this, you can switch off the video. Just be on the audio, but you have to share your screen.
Sir, now it is okay, sir.
Yeah. Now it is okay.
Go to full screen.
Put it on full screen. Go to that slide.
Yes, sir. So, while examining the patients, the patient may...
Did you finish the previous slide?
Yes,
sir.
Go to
even if you finish, we didn't hear. Your voice got disconnected this time. So start off from this slide.
Okay, sir. how we evaluate the case of obscure GI bleeding is, in the case of obscure GI bleeding, the history and physical examination is so important to know the etiology of the obscure GI bleeding. Repeated upper and lower GI endoscopies is the main very important for the diagnosis and management of obscure GI bleeding. Repeated upper GI and lower GI endoscopy should be done in all patients in which experienced operators pick up 20% of the cases.
Pavan,
Yes, sir.
if you have to do endoscopy in patients who have already been evaluated once,
Yes, sir.
what kind of endoscope will you use? Because there are important, endoscopic advances that you have to use to
Yes,
pick
sir.
up these kind of bleeds. What kind of endoscopes will you use?
Sir, sir, like balloon enteroscopies.
No. We are not talking about balloon enteroscopy. We're talking about upper J and lower J endoscopies.
So,
Balloon enteroscopies is for small bowel. That is
Small
for
bowel.
yes, sir.
75%.
Yes, sir.
You have quoted the statement. So, sir is asking for what kind of endoscope you will use to pick up those 20% of cases.
Sir.
Okay, I think there is something called chromoendoscopy and magnifying endoscopy where you get very magnified views. So you may small lesions which may be actually bleeding may be missed by ordinary endoscope, but you have a magnifying endoscope which will magnify the mucosal details so that you can pick up lesions which you would have missed otherwise. And then there is chromoendoscopy where you spray dye and then look at the area which you have sprayed, and
Yes,
that you have to take. Normal endoscopy takes about 3 to 5 minutes. This endoscopy will have to do for 45 minutes to in individual areas you have to carefully spray the dye and then examine under the endoscope, and then you may be able to pick up certain lesions. Okay.
yes, yes, sir. Okay, sir.
So, in nearly 75% of your obscure GA bleeds, the
Yes,
cause will be found in small bowel. In the
yes,
rest
sir.
25%, either the cause will be in the upper GA or in the lower GA, that is in the colon. In among those 20%, you can pick up. In the remaining 5%, in spite of all these investigations, you can still miss. That means it will not be obvious. The cause will not be obvious. Okay, so
Yes, sir.
continue. Yeah.
Sir, one question, sir. Sir, this chromoendoscopy will
Yeah.
not be readily available now, sir.
It is not readily available, but wherever it is available, you should use it. It's expensive.
Hi, baby.
But I think slowly it is coming in.
Okay.
Okay.
Continue, Tom.
Yes, sir. For evaluation of the obscure GI bleeding, the clinical presentations like whether there is a bleeding or not, having nature of bleeding like hematemesis, melena, or hematochezia, some bleeding diathesis like von Willebrand factor deficiencies, if patient having a medication history of using any aspirin or NSAID usage, and any comorbidities like any vasculitis or valvular heart diseases, or previous any surgeries like any anastomosis, and prior radiation therapies, and family history is so important in case of inflammatory bowel diseases. And finally, the physical examination is so important to rule out systemic syndromes.
Pawan,
Yes,
two
sir.
things. One, you said nature of bleeding. What do you mean by nature of bleeding?
Sir, nature of bleeding means the patient may present with either hematemesis or melena or hematochezia, sir.
Okay.
Hematemesis, yes,
How
sir.
does it help?
Sir, if it is a melena means probably the cause may be some upper GI cause, sir.
Continue.
And fresh blood may be, and if the patient present with some hematochezia means there some lower GI causes will be there, sir. Lower GI cause. Depending on that, we can rule out whether some upper GI, or we can have an idea regarding that, sir.
Is there any variation to that?
Sir?
Is there any variation? What I mean is, melena can be if at all if patients have melena, you
Yes, sir.
always consider that it is upper GA, or is there any lower GA is, bleeding also can cause melena? Or if it is fresh bleeding, if you have seen fresh blood in the stools, does
Yes,
it
sir.
mean only in the lower GA, or it can be upper GA also?
Sir, it can be upper GI also, sir.
When? Anybody else? PG?
Then it is a massive bleeding, sir. Continuous
Yeah,
massive.
correct. So if it is a massive GI bleed in the upper GI tract also, they can present with fresh bleeding.
Yes, sir.
And also
Aortic.
patients with fecal impaction and constipation, if patient is bleeding from the distal ileum or the colon, they will also present like a melena. So it is not, although majority of the times it will be accurate, there can be variations to that also. Yeah, sir was telling something. Sir, Ravishankar sir, you are telling.
No. Continue.
Okay. There are a few questions there.
Yes, sir.
Ravishankar sir is asking, when do you see aortoventric fistula?
Sir, in the case of some abdominal aortic aneurysm repair, in that conditions, there may be a chance of aortic enteric fistula, sir.
Okay. Why does that happen?
Sir, during aneurysmal repairs, no, sir.
No. Aneurysm repair has been done properly.
Yes, sir.
So what happens? Why do you get aortoenteric fistula? Anybody?
The probably infection of the graft, sir, aortic graft, and leading to erosion.
That is one condition, and then infection. See, normally what you do with aortic aneurysms is you have to close the aneurysm sac over the graft and make sure that the graft is not exposed. Just like we try to, close the, the hernial sac over the mesh so that the mesh doesn't get exposed to the bowel. The same thing you have to do with the graft as well. So in case there is any small window where the graft is exposed, the bowel will go and get attached to that, and that can over a period of time, because the pressure in the aortic graft is very high, 120 millimeters of mercury, and the bowel is not used to taking that kind of pressure. Over a period of time, it will erode the bowel wall, and then there will be aortoenteric fistula.
Yes, and sir, this will also cause fresh bleeding.
Yeah, it can cause fresh bleeding. Yes.
And I think Saurav has answered for some history of previous vascular surgeries like aneurysm.
Yeah, that's the thing.
So that is there. Ajit is asking how much bleeding should happen for patient to notice PR bleed. Pavan.
Sir.
Oh, and how much should the patient bleed for him or her to notice PR bleeding? Or like 5 ml will the patient notice?
You mean if you exclude the perianal causes of GA bleed?
Yes.
That is what you are asking, right?
Yes, sir.
Okay, Pavan.
Then,
if you know, you tell, you either say the answer, otherwise you tell don't know. Don't waste time.
Okay, so don't know.
Ajit.
Sir, 100 to 150 ml, sir, for the patient to notice.
Yeah, correct. Okay. Continue, Pavan.
Yes, sir.
And one more, you said family history for
Yes,
what? Chronic inflammatory bowel disease.
Yes, sir.
What else? Family history is, rather than inflammatory bowel disease, it need not run in families. More than that, there are those hereditary purpura and all those things.
Yes, sir.
So for those, I think family history is relevant.
Correct.
Rather than inflammatory bowel disease alone.
Yes, sir.
Ravishankar sir?
Yeah, you're absolutely right. Familial inflammatory bowel disease is a small portion of the whole thing. So I don't think you need to worry about it.
Yes, sir.
Okay, continue, Pawan.
Yeah. Coming to various procedures to find out the obscure GI bleedings, like starting with push enteroscopy.
Pawan, here you have to tell, you have
Yes,
to,
sir.
again, after an initial endoscope and colonoscopy,
Yes,
you
sir.
can repeat the endoscope and colonoscope after the bleeding is stabilized also. Okay,
Yes, sir.
so in up to 20%, you can identify the source of bleeding in upper and GI. If it is not, then you go ahead with all this additional endoscopy.
Investigations. Yes, sir.
Yeah, continue.
Push enteroscopy. Uh, it push enteroscopy is a endoscopic procedure uh, in which the scope is flexible and passed through the mouth, and we will examine approximately 50 to 500 centimeter of
500.
the 50 to 100, sir, 50
Ah.
to 100 centimeters distal to the ligament of trees, and the diagnostic yield of the push enteroscopy is around 3 to 70%, in which
That's a
majority.
huge. That's a huge range, man. Is that right? Varies 3%, varies 70%. That means you can get it wrong as much as you can get it right.
Yes, that is correct. That is a variation which is there in literature.
Okay,
Push
okay.
enteroscopy. It depends on operator dependent
Yeah.
again, and not everyone will be able to do that push
Do the
enteroscopy
yeah.
successfully.
Non-completion of the procedure
Non-completion.
itself probably the reason for such a low yield.
Hmm.
In which,
And
yes,
continue.
in which majority of the small bowel findings being the vascular lesions. So the disadvantages of the push enteroscopy is as it in while doing the push enteroscopy procedure, looping of the enteroscope, and patient comfort will be there, and it is limited to proximal small bowel lesions, and now it is replaced by new other techniques like capsular endoscopy and balloon enteroscopies. Coming to intraoperative endoscopy, in which it can be done via an enterotomy at open surgery. The yield of this procedure is around 70 to 100% depending upon the severity of the bleed. Initially, the first step during this intraoperative endoscopy is laparoscopy or laparotomy to see which part of the bowel is has blood in it, and then for example, if the proximal bowel has no blood in it, and we have to check the distal bowel in great detail, and the small bowel enterotomy, that is the distal bowel of the jejunum, we have to give an enterotomy, and a sterilized enteroscopy should be introduced to it, and it is manipulated both proximally and distally to see the cause of the bleed. In this, the operating surgeon helps the endoscopist to process the threading of the bowel.
Pawan, in what category of patients of obscure GI bleed you do intraoperative endoscopy?
Sir, after doing all the endoscopic procedures and we are not able to find the cause of the bleed, no, sir.
No. You
So
have
in all
to
patients,
classify.
what is the category of patients you have to operate?
Sir,
Because you yourself told 80% will not require anything at the end of 2 or 3 years. In this
yes, sir.
obscure GI bleed patients, in your introduction slide, if you say you yourself quoted that 80% of patients there will not be any this thing after 2 to 3 years.
Yes, sir.
So categorize them.
In obscure occult bleed, no, sir. After
Obscure occult bleed, there is no role for intraoperative endoscopy.
Obscure overt bleed, man.
overt, sir.
If the bleeding is very severe,
Yes, sir.
okay, then and the patient is very unstable, you don't have any time for any other investigation, and you have ruled out the upper and lower GI causes, that is colon and stomach.
Yes, sir.
Then you do that, take the patient up for laparotomy, and then at that time you do intraoperative endoscopy to identify the site, not in obscure occult,
Yes, sir.
because it is self-limiting in majority of the cases. And if there is any identifiable source like NSAID and all the other antiplatelet agents, most of those bleedings may not happen again, or then they're self-limiting. They can stop after 1 or 2 episodes.
Yes, sir.
Yes. Continue.
Coming to capsule endoscopy, it is a non-invasive procedure in which there is a small capsule with a video camera. It is swallowed and it captures video images while passing through the GI tract. So it is used in the patients who are hemodynamically stable and having a continuous bleed. So the success rate of the capsule endoscopy is as high, that is 90% in identifying the small bowel diseases. So the advantage of the capsule endoscopy is it helps to visualize the entire GI tract, and disadvantages is that is the most common disadvantage is capsule retention, and as it is a time consuming process and it is costly, and it is not suitable in patients with obstruction or motility disorders. The
What is the most important problem with capsule endoscopy, man?
Sir, capsule retention, sir.
No.
That is a complication.
Complication. Problem.
What is the problem?
Anyone know how many images a capsule endoscopy does?
Sir, two per second.
Huh?
Around 2,000 to 3,000 images will be there, sir.
I think that you are grossly wrong.
Sir, okay, 2 per second. Per second, it will take 2 images.
So how many images will be there? I think roughly between 1.5 to 2.5 lakhs, man. So you need an expert radiologist to sift through this so many images to pick up the lesion. So actually, I have personally met the person who actually invented capsule endoscopy in South Manchester University Hospital. I forgot his name. So he said, he's become so famous. He was getting so many referrals for this, and he couldn't go through all these images. He said, I don't know why I invented it. So that is a problem. It is too many images for you to go through, and I think that is why if you can, then you may pick up lesions if they are there.
So the percentages quoted in this slide is a little bit high, no, sir? 90%.
Yeah.
It varies between 45 to 90 in the literature.
Yeah. So what is the advance in capsule endoscopy, man? Anybody?
Sir, able to access the areas of bleeding, sir, midgut.
Which we are not able to access by endoscopy or colonoscopy.
No, but what is the advance? No, that is what is the advance that you have newer capsules? What do they have?
A magnetic capsule endoscopy, sir.
No. I think you have, sort of, it has got a GPS kind of thing where you can control the capsule, and then also it has landing facility also. It can land certain areas and things like that, which you can deploy from outside. So that is you can control the movement of the capsule from outside. That is supposedly the latest one. I don't know whether it is available in India.
Sir,
and one more advancement is the loading device, capsule loading device. Those who are not able to swallow, endoscopy it can be attached to the channel of the endoscope. You go in and then inside there and drop it and come out.
Yeah,
that is one more advance. Yeah, I think there is one more question. Or question or clarification. I think, is it Dr. Atmaram, sir?
Yeah. I just wanted to ask. He said the site of enterotomy is at the distal jejunum or mid jejunum. But in our experience, I just want to tell, I don't know, Lakshman sir has to tell us that we have always never gone with a prefixed idea of enterotomy at any particular site. Wherever actually blood is an irritant in the small intestine, so it keeps going distally. So the site of bleed usually is about 100 to 200 centimeters from where you can see blood in the small intestine, especially in the small intestine bleeds. So our enterotomy site is usually 100 to 150 centimeters from where we can see blood. The entire small bowel will not have blood.
That is, you mean proximal to the site
Proximal.
of blood. Correct.
Yeah, wherever we can see blood in the intestine, we should go 100 to 150 centimeters proximal to it. Lakshman Sen can correct me if I'm wrong.
No, you are absolutely right, Atmaram. I think you have to see where that is why you have to do an initial diagnostic laparoscopy, find out where the blood is, and then go proximally. You are absolutely right.
Yeah, the
And one more thing
site should
to
not be
add
prefixed when you're going. I would only recommend that go with an open mind, see where the blood is, and go way proximal to where you can see blood. Say 100 centimeters to 150 centimeters from the place where you can see blood.
And also one more thing to be noted is you don't only go distally, you go proximally also from the site of enterotomy.
Yeah, definitely. That is my point. That please look proximally from where you can see blood. That's my major point. That's all. Yeah. Thanks.
Continue.
And sir, one thing I want to add. For upper like esophagus and esophageal bleed is there. If it can be missed by capsule endoscopy because it will move fast. I read like that.
For esophageal bleeding, we never do capsule endoscopy.
Capsule endoscopy, man. Why do you want capsule endoscopy?
No, sir. Obscure if it is not visible by.
No, even if it is for obscure, capsule endoscopy is mainly for small bowel lesions.
See,
It is never for colonic or this one.
See, Ajit, when you do an upper GI endoscopy, Saurav, just a minute. When you do an upper GI endoscopy, you go through, you carefully, go from the, pharynx, as you've seen me do it. You have to look at the, tonsillar fossa, everything. You go very carefully, and especially if there is bleed, you go carefully and see everything, and you will find some telltale signs that, there will be blood or, clots in the stomach or whatever, which will tell you that the bleeding is in that area. You cannot have an esophageal bleed with where blood disappears into thin air. It will have to go through the stomach, so there will be blood in there. So you know that it's coming from esophagus or stomach. So that is why it's very rare to have esophageal, obscure bleeds. Okay? Okay.
Thanks.
Saurabh, you had...
No, sir, I was not asking it.
I heard somebody,
I just had a comment that just because an investigation is available, please don't do it. Upper GI endoscopy, if you're expecting an upper GI bleed, if you're doing capsule endoscopy, then it's an overkill. And definitely you have to read more, understand more, see more.
It is not indicated. Capsule endoscopy is only done for obscure occult GI bleed.
Colonic bleed.
It is not done in overt GI bleed also. It is in occult GI bleed where small bowel is the culprit.
Yes.
Where we have ruled out all possible causes of GI bleeding in the stomach, esophagus, stomach, and the colon and rectum. Yeah.
And nowadays, I think this guy forgot to mention Pavan. See, now CT is available very freely, and CT, contrast CT, contrast enhanced CT, or CT angiography is a better investigation, especially in overt GI bleeds, because it will tell you where the bleeding is, and then you can concentrate on that area. So I think before you do all this, this double enteroscope, all those things, which are first of all not available in many institutions, you have to concentrate on what investigation that is available across the board. Good CT is available in most good hospitals. So you should concentrate on what investigations which will give you the answer.
Yes, sir.
Go ahead.
Go ahead now.
Yes, sir. The image in this slide shows a small bowel tumor with ulceration which is detected by the capsule endoscopy. And similarly, in the case of angioectasia with mucosal scalloping of the small bowel which is detected with the help of capsule endoscopy. um, Balloon assisted enteroscopy. So it uses the principle of the push and pull enteroscopy, and it can be performed either anterograde or retrograde manner, and it can visualize the entire length of the small bowel. So it comprises of single balloon enteroscope and double balloon enteroscope. In single balloon enteroscope is a technique which is used for evaluation and management of the small bowel disorders, and it has a risk of perforation in patients with small bowel lesions. Whereas in double balloon enteroscope having an overtube which helps to allow deeper intubation of the small bowel of around 250 to 350 centimeters in anterograde approach or 100 to 150 centimeters in retrograde approach, having a diagnostic value of 60 to 80, and this double balloon enteroscopy having both diagnostic and therapeutic value. And the disadvantages of double balloon enteroscopy is it is invasive in nature and having a long time consuming, and complications like ILS, pancreatitis and perforation may also occur. The image in this slide showing left side of this slide showing the single balloon enteroscopy, and the right side of this slide shows double balloon enteroscopy in which this overtube which helps in allowing the deeper intubation of the double balloon enteroscope. So with the help of double balloon enteroscopy in the proximal ileum, Dufella lesion is seen. Dulophi lesion. And whereas similarly with the double balloon enteroscopy, deep ulcerations in the distal ileum can be seen in this image.
What is the advantage of this single and double balloon enteroscopy over your capsule endoscopy?
Sir, this having a therapeutic uses, sir. If there is any bleeding like that, we can therapeutically manage it, sir.
Correct. Okay.
Yes, sir. And spiral enteroscopy, it is enteroscopy in which we are using either in clockwise or anti-clockwise movements in advancing and withdrawal of the enteroscopy through the small bowel, and we can visualize the GI tract. So the advantages of this is also therapeutic capability and having a disadvantage of sore throat with minimal mucosal trauma. So the diagnostic laparoscopy is used to diagnose and treat the underlying cause of the small bowel disease which causing obscure GI bleeding. After doing this diagnostic laparoscopy, the affected part or diseased segment can be done either laparoscopic assisted resection, segmental resection, or enterostomy can be done.
No, Pavan,
Yes, sir.
diagnostic laparoscopy, isolated diagnostic laparoscopy has a very minimal role.
Yes,
You
sir.
have to combine diagnostic laparoscopy with your intraoperative endoscopy to identify the exact site of obscure lesion.
Yes, sir.
Okay.
Yes,
So diagnostic laparoscopy probably will help you in localizing the site of GI bleed, like
GI
gist
bleed.
or something.
Yes,
Small
sir.
bowel gist where you have identified it by some other source, like CT
Yes.
scan or whatever. So
Yes,
to
sir.
pull out that part of the bowel, or you do it laparoscopically. Other than that, isolated diagnostic laparoscopy has very minimal role. So you have to club it with intraoperative endoscopy.
Endoscopy. Yes, sir. So can I continue, sir?
Yeah.
So coming to various radiological images to
I think one question is there from
yes,
Dr.
sir.
Atmaram.
Yes,
Can you
sir.
describe a gulofoil lesion? What is gulofoil lesion?
So, gulofoil lesion is a large tortuous arteriole which is present in the submucosal region of the gut, sir.
Good. How do you identify it intraoperatively?
Sir, thank you.
Good. Whatever you told is good. I just want to know, gulofoil lesion, where do you commonly see it? If you get as a short note, you have to write something, right? You just can't write a giant arteriole submucously seen.
Yes, sir.
Yeah.
Sir, lesser curvature of stomach, sir, most commonly.
Commonly seen in stomach. Very good.
Yes. Then duodenum, I think, second most common.
Yes, very good. What are the characteristics of it? I think you should see when you're mentioning something in your slide. My only thing is,
Read up
if
about
you
it.
mention I wouldn't have asked anything about gulofoil lesion. If you mention something in your slide, you should read something about it. Okay.
Yes, sir.
It's a case which was done in Sagar Hospital when I was a resident at Sagar. And I presented a paper also.
Yes, I know about this case, sir. Lakshman sir had told me once.
Yeah. So you should know more about it. Okay. Read about, if you have put it on your presentation, please read about it. It's very important to know. It comes in your exams as well as in your practice. Okay.
Yes,
I'll
sir.
not digress from the topic, but I want you to know what is gulofoil. That's all. Okay.
Yes, sir.
Right. Continue.
Atmaram, it's not digression because that is what they are supposed to do.
Right.
Everything that they put it up on the slide, they should read up about it.
Yes,
I
sir.
think I told the same thing to Pavan few days back. He was not knowing many of the things which he himself had put up in this presentation.
I'm pretty sure you would have wanted to read about Dulofy, so he's read the one definition of Dulofy and has put it. But it's an opportunity, Pavan, for you to know that Dulofy is not only a short note. It can come in your clinical practice. You should be ready. You cannot read about this when you get the case. You should be ready. This is a great opportunity you have got to learn about such a lesion. You should have learned more. That's all I wanted to tell you. Please use these opportunities to learn more for yourselves.
Okay, sir.
Continue.
Okay, come on, continue.
Radiological images of the small bowel foul bleeding includes contrast enhanced CT, the CT angiography and CT enterography and MR angiography. The contrast enhanced CT helps to demonstrate the small bowel tumors which may be cause of the bleed, but it fails to demonstrate the subtle bleedings, subtle findings.
Okay, anybody in this one, can you tell us what is difference between a CT enterography and a normal contrast enhanced CT? He has specifically mentioned CT enterography and MR enterography. What is the difference between a normal CT, oral contrast CT or a rectal contrast CT compared to a enterography? Saurav or Rajit or Abdul?
Sir, when we do the normal contrast enhanced CCT abdomen, that will evaluate everything, sir, including small bowel as well as large bowel. Enterography only small bowel, and I think the contrast use will be different contrast is used, sir, for this.
No, only
What
difference between anybody else?
Yeah.
Hello.
Yeah, Saurav? Silence. Golden
No,
silence.
sir. No, sir. Don't know, sir.
Abdul?
Sir, it uses both IV contrast as well as oral contrast given together.
No.
After oral contrast is gone
Yes,
through,
after oral they give IV and then they visualize.
But why is it called enterography? Then you just call double contrast enhanced CT. But why is it called enterography?
Because able to visualize the entire thickness of the small holes.
See, what is important is for you to appreciate the mucosal detail of the small bowel because you want to pick up small lesions. So, in that case, what you do is you give them methyl cellulose along with contrast. The methyl cellulose expands the small bowel, and then the contrast, either it used to be barium before, now you can use gastrographin. So, when the bowel is dilated, then the contrast is coating the bowel wall, then you can appreciate smaller lesions which are not otherwise seen. So that is the difference between an enterography and a normal contrast enhanced CT. See, the contrast just flows through because, as you know, contrast is a very powerful cathartic. It is hygroscopic. It absorbs water from the bowel wall and flows very quickly. So, unless it's a gross lesion, of course, it will pick it up. Now we are now talking about obscure GI bleed. So it won't be gross lesion at all because normally it would have picked up anyway. So you have to do an enterography because you want to appreciate the mucosal detail. Niranjan, anything else?
Nothing, sir. Same. Correct.
Okay.
Yeah, continue, Pawan.
Yes, sir. CT enterography, it helps in diagnosing the conditions such as Crohn's disease, Meckel's diverticulum, and angiodysplasias, and having a yield of 40%. As now sir told that it helps in identifying the mucosal um, regarding the mucosal details and regarding CT angiography, it helps in identifying the active GI bleeds as seen as a extravasation of the contrast into the bowel lumen, and it helps to demonstrate the bleeding in which the bleeding rate is around 0.5 to 1 ml per minute, and thus it has a sensitivity and high specificity. The image in this slide shows the CT tomographic image in which that there is a aortovenous malformation is seen in the contrast image, and the image below shows that is the heterogeneous hepatic enhancement and early venous return in the dynamic CT. So coming to the nuclear imaging, in which we can diagnosing the site of the bleed using radioactive material technetium 99 labeled RBC, and it detects the bleeding rates as low as 0.5 ml per minute. And the disadvantages of this nuclear imaging is it is costly and it lack of availability and having false positive localization of tagged blood cells within the lumen during peristalsis.
Pawan, I think at this point of time, the quoted two disadvantages, the first two disadvantages are probably not right. The third is
it has become relative now. Cost and lack of availability is very relative.
It probably costs few thousand. That's it. So it is lesser than cheaper than your regular CT also. And lack of availability also in most of the small district centers also it is available now. So only relative disadvantage is false
positive localizations.
Ravi Shankar sir, anything to add?
Yeah, correct.
Also, please note, all this can be done when the patient is very stable and, the bleed is very small. And as Niranjan had pointed out earlier, these bleeds are usually probably self-limiting bleeds, when you're already going to technetium tagged RBC scan or CT angiography, probably patient is very stable. This is just to find out. Continue, please.
The image in the slide shows positive RBC scan localization, which localizes the site of bleeding in the left lower quadrant.
It cannot localize to the exact anatomical location. It only gives us the quadrant in that area.
Yes,
So
sir.
it can be colon, it can be small bowel, it can be stomach also. So that is the disadvantage of this particular scan. It only says whether there is active bleeding or not.
Yes, sir.
Okay.
So, according to European Society of Gastrointestinal Endoscopy clinical guidelines, it suggests to perform video capsule endoscopy for both occult and overbleed, and if the results are positive, specific management has to be done, like device assisted enteroscopy, and depending upon, we may consider other treatment based on the VCE findings, and we can also device assisted enteroscopy can be directly done in case of overt bleeding. If the test results are negative, and clinical follow-up has to be done, and if any recurrence is there, then we have to go for uh, video capsule endoscopy or device assisted enteroscopy. And in the case of suspected small bowel bleedings, according to American College of Gastroenterology, in case of suspected small bowel bleeding, if it is an occult or overt bleeding, on repeated endoscopy, if it is positive, we have to treat the underlying cause. If it is negative, we have to evaluate for further small bowel cause of this, and if there is any obstruction, we have to go for, if there is any obstruction, we have to go for CT enterography or MR enterography. If there is no obstruction, then we may consider video capsule endoscopy, and if it is positive, then specific management, like specific management for the cause of the disease. And if the CT enterography or MR enterography is negative, and we have to further evaluate and on repeated endoscopies, and if it is negative, we have to observe the patient and supplement iron supplements. So the management of the patients of the obscure GA bleeding, depending upon the clinical presentation, whether it is obscure or occult GA bleeding, or and depending upon the nature of the bleeding, whether it is melena or hematochezia, duration and frequency of the bleeding, and severity of the bleed, and when the need for any blood transfusion, and presence or absence of any iron deficiency anemias associated with clinical symptoms like abdominal pain and weight loss. Depending upon this, we have to manage the patient. And the medical management, if all these radiological and surgical and endoscopic methods are failed, the medical management have a little role. It includes some hormonal therapies like estrogen with or without progesterone, which improving the vascular integrity by decreasing the vascular angiogenesis by inhibiting endothelial growth factor. So the usage of ethinyl estradiol along with or without norethistyrone can be useful in some patients in hereditary hemorrhagic telangiectasias. And somatostatin analogs like octreotide and thalidomide, which is having some anti-angiogenic property, and erythropoietin and von Willebrand factors. So all these modalities do not appear to be useful in long-term medications, in which the patients having a rebleeding chances of around 46% after medical management. Thank you, sir.
Yes. Sir, any questions? Ravishankar, sir?
For this is for Pavan, or it's not Pavan, for Ajit and Saurav or Abdul. If you, let us say you found angiodysplasia in a segment of bowel, how do you manage it? Ajit?
Sir, by Endoscopy, sir. Endoscopic. We
Okay.
can
What do you do with endoscopy?
cauterize.
Not electrocoagulate. You use
Electrocoagulate, what cautery? Your regular cautery you use.
No,
what?
no.
Then what? Argon
Organ.
plasma
Organ,
coagulation.
Yes,
Argon plasma coagulation. Okay. So if you have the facility for double lumen enteroscopy and you have the expertise to do it, you can do that. Okay. What else? What is the recurrence rates with this recurrent? It is up to 50 to 60% because you have angiodysplasia in a segment and you deal with that. Newer segments will open up and that can cause further bleed. So that is why it is a problem.
sir.
So
Then
what do you
when
do?
this,
What do you do if it is do surgery wise?
Segmental resection, sir.
Okay, segmental resection. What specific precautions do you take when you do segmental resection?
Um,
See, the thing is angiodysplasia doesn't just, for example, let us say you see a leash of vessels or whatever, it doesn't, confine its like what is required because even though the angiodysplasia is obvious in this segment, there is clinically occult angiodysplasia in areas adjacent to it. So that may open up later. So you have to resect a bit more than usual. That is definitely one of the principles of angiodysplasias of bowel.
okay, sir.
Niranjan?
Anything? Okay. Atmaram, sir. Anything else, sir? You want to ask or
No,
clarify?
no, I don't have any
All right.
questions. But Pavan, I do have recommendations for your slide presentation. You really have to practice. I think most of it you are reading. You presented well. I'm not saying you didn't present well. Good presentation. Content was very good. Slides were very well made. But you have to practice your presentation. You're most of the time you're reading. Your confidence will be boosted only if you practice. It looked as if you're trying to practice there on slide presentation now. It only gives you an opportunity to present better if you practice more and many more times. Content was very good, but I think you can improve on your presentation. That's all I have to say.
Totally
Okay,
agree, sir.
okay, sir.
Yeah. Pavan, and also since you learnt this time that
Yes, sir.
there is no role for cut and paste job.
Yes, sir.
Yes.
Okay. Yeah. So we have to learn. It's almost 6 months now. So
Yes,
the basics of presentation and this scientific meetings, whatever we are doing, is for your benefit. If you just cut and paste and come and present here, read it off, it will not be of any benefit to you. It is not for us, but for you. You have to go through various not you have to go through various articles, review articles, rather than just looking it from Bailey and Love or Sabiston and coming and presenting it from there.
yes, sir.
I think Dr. Lakshman, all of us have told you many times, once you become a postgraduate, textbook reading is only a small portion of it. It's basic foundation reading, but majority of your reading has to be in peer-reviewed journals. It
Yes,
has to be compendia, journals, review articles, meta-analysis, all these things. So you can't just concentrate on textbook and say, of course, your basic presentation has to come from there. But as you know, textbooks are minimum 5 to 6 years behind the current literature
correct.
because
Yes,
it takes that much time to produce a textbook, and the literature available in the textbook is already old.
yes, sir.
And
Okay.
with the way that things are growing now, you have to read journal articles.
Yes, sir.
I didn't see any journal article quoted in this, which is very disappointing. I
Yes,
told
put it
you,
up. Yes, put it up in the bottom
Sir.
in few this
Yes,
thing
sir.
slides.
yeah, but
Earlier,
I
it was
told
everything was from Sabiston.
Sabis,
Okay.
good
Any
job.
other questions or anything? Any clarification from anybody else side?